Hi, good evening, everyone. We welcome Dr. David Yeo, who is my friend, actually a friend of a friend. We get along very well because of certain things that we like to do, like drink and party and eat. But Dr. David Yeo is a very experienced and doctor who has been in Makota for 20 years. Makota Melaka, right? Before that,
Yeah.
where were you?
HKL.
HKL. So I think we are going to start broadcasting live to Dokwiti if we have not. Faisal? Where is Faisal?
Yes.
Okay, so we can actually start with your slides now, and then
Okay.
we go ahead.
All right. So I will start sharing my slide first. Let me
Tanya semalam dia.
Okay, hold on.
Tak tengok dia punya.
Wait, let me just mute. Hold on. Okay.
All right. Let me see. Let me get my slide ready. Just hang on.
Yeah, sure.
Here. Okay. Thank you, Betty, for inviting me to this to give a talk on this Docuity webinar. I'm very grateful. And of course, thank you.
Hold on. I just, yeah.
Can everyone hear me? I hope everyone
Yes.
can hear me. All right.
Everyone can hear you.
Yeah, thank you, Betty, for a kind introduction and also for inviting me to talk on this webinar. And of course, how is everyone doing? I hope everyone had your dinner and have some time to spare with me to talk about depression. I hope none of you are depressed now. So hopefully that everyone will enjoy my talk. It's going to be a short talk where I will discuss about differential diagnosis of major depressive disorder, because I find that I think some of you are physicians and some of you are gastroenterologists or some of you are general practitioners. So I'm sure that each of you and one of you have seen someone want to come to you feeling depressed, right? So in your clinic, in your consultation room, you see people come in feeling depressed. They tell you, I'm feeling sad, I'm feeling depressed. So are we going to diagnose this as a major depressive disorder? Yeah, so it may not be major depressive disorder. So this is about today's topics, right? So are we going to say that everyone who come to our clinic, come to our consultation room, who telling you they are depressed, you straight away say, oh, this is a depression case. I want to send it to psychiatrist or give you antidepressant. So it may not be the case. So that's why my discussion is about differential diagnosis. Are we going to straight away diagnose depressed case as a major depression disorder or something else? All right. So my outline for today is basically I want to talk about the common mental illnesses where patient presented with depressed mood. I'm going to talk brief about MDD to recap, because I think some of you have forgotten, maybe from the medical school, you all learned about MDD. And after a while, when we grown up and then we went to work as our own specialty, so we have forgotten what is MDD. So I'll talk a little bit about MDD. And then I will want you to learn about various mental illnesses that presented with depressed mood. All right. So today online is basically very simple, only three main topics. All right. Good. So who are the patients come with depressive mood? Okay. So of course, first on the top of the list will be MDD, major depressive disorder. Second, of course, people with schizophrenia, they can come with a depressed mood. Sometimes a schizophrenia patient who come in, they tell you, I'm feeling depressed, but you didn't know they are actually schizophrenia. When you dig further in, you ask for the history, you found that, oh my God, he is actually a case of schizophrenia with depressed mood. So we have to be careful. And bipolar disorder case, sometimes they come in with a depressive episode. So they have all the depressive symptoms because they are in the depressive phase. So are we going to diagnose them as MDD? No, they are actually bipolar affective disorder, right? So I have to remember that. And anxiety disorder, when you see people with anxiety, if you ask about depression, they always be there. They're always the comorbid. For me, in my practice, I think most of the patients who presented to me with either anxiety or either depression, they have this comorbid. It means anxiety and depression always come together as one. So they are like sibling. I always tell my patient like this anxiety and depression are like sibling. They're always together. So this could be a case of comorbid anxiety depression, not only a major depressive disorder. All right. And another simple one, like some people come to you in your office saying that I'm sad and I'm just because I just broke up with my boyfriend, or just broke up with my girlfriend, or have some conflicts with my family, or I have a fight with my husband, or I'm with my wife, they're feeling depressed. Are you going to diagnose them as major depressive disorder? No, right? You're going to say adjustment disorder with depressed mood, or adjustment disorder with anxiety distress. So these are the differential diagnoses. So that's why we have to be careful. It's not like everyone is MDD. All right. So obsessive compulsive disorder, people with obsessive compulsive disorder also can come with depressed mood. They present to you as depression, but then when you dig further, you find that they actually have OCD. So OCD and depression are quite common, right, in our everyday life. Eating disorder, people with anorexia nervosa, bulimia nervosa, all these people can come with depression. And people with post-traumatic stress disorder, PTSD, like some people develop PTSD after the COVID. So these are people who come with depressed mood. So they actually post-traumatic stress disorder that come in with depressive symptoms. And of course, acute stress disorder can also present with depressed mood. And of course, some medical condition like Parkinson's disease, Alzheimer's disease, some cancer patient, all this can come with the depression. So are they going to be MDD? They may not. They are because they are due to the medical condition, right? And substance abuse are people who abuse drugs, abuse a lot of alcohol, can present to you as a case of depression, a case of a depressed mood. So we're not going to tell them that you are actually major depressive disorder. You are actually substance abuse with depressive symptoms. All right. So these are the people that we have to watch out. These are the differential diagnoses we have to watch out. We are not just going to stick to MDD only. That's what my main heading for today. All right. I hope you get it from me from now. Okay, so let's talk a little bit about MDD, because I think this is just a recap. I'm sure every one of you have quite expert in dealing with MDD. Of course, besides the psychiatrists, I'm sure some of the physicians, some of the GP are pretty good in dealing with this MDD case, right? So what are they? They actually, we have criteria for MDD. We follow the DSM-4, DSM-5 now. So it has to be, the symptoms have to be depressed mood, loss of interest or pleasure in all activities. There is a weight loss, or either weight gain or weight loss, either increase or decrease in appetite, and either insomnia or hyposomnia, or psychomotor agitation or retardation, or feeling of worthlessness, fatigue, diminished ability to think, cannot focus, cannot concentrate, recurrent thoughts of death. So it has to be 5 or more of the above symptoms. Because I mentioned about 10 symptoms, it has to be 5. And for 2 weeks period, we have to remember it's for 2 weeks period. And one of the symptoms must be either depressed mood or loss of interest. This is very important. When you want to diagnose MDD, it has to be one of the symptoms must be depressed mood and or loss of interest. All right. Okay. Then the criteria B, the impairment in social, in occupational, or that means they can't really function, they cannot mix with their friends, they can't go to work, they can't do important things. And of course, the criteria C will be they are not due to any substance abuse or any medical condition, right? All right, so these are the criteria for you to diagnose MDD. Management, as in medical school, we learn about biopsychosocial. Again, in today's condition, we still use these 3 things that's in biopsychosocial to deal with treatment of the major depression disorder. Okay, of course, biological, we are using antidepressant. As you know, in the market, we have a lot of antidepressant now. We have SSRI, we have SNRI, and of course, other new groups. And of course, you can use a bit of anxiolytic. Because I can't see the audience, so I'm not sure how many of you are using anxiolytic like Xanapam, Lorazepam, or Diazepam, or Clonazepam. I'm sure it's okay to use. For me, it's okay to use, but it's for the short time because we need to wait for the antidepressant to work. So we can use this anxiolytic for 2 weeks, and then after that we can stop it. So because you are afraid of dependency, so it's okay to use it. I'm sure like some of the GPs out there or some of the physicians, they like to use Xanax, right? So Xanax, a little bit of Xanax is fine for the first few weeks. After that, we tear off the Xanax and then just continue with the antidepressant. So it's okay. Then of course, the other treatment, as I say, psychological treatment, of course, you go for counseling, for one-to-one counseling or brief psychotherapy or supportive therapy. And of course, socially, that involves the family, how the family can help the patients, and of course, how the friends and family can help the patient of MDD. So again, I stress on biopsychosocial, the 3 components of treatment of MDD. Okay, I hope you understand. I hope I'm not going too fast. All right. All right. So next, so the treatment phase for MDD is we want to get them to respond. Of course, first 2 weeks, of course, the first 2 weeks to 1 month, we want to see the response. That means they are getting better. And then they achieve remission. Then, of course, recovery. We want them to have recovery, right? Functional recovery. I like to use the word now, functional recovery. It means they can function, they recover from their symptom, but they still able to function. It's not like they have no depressed mood anymore, but they cannot function. That is not recovery. That is no symptom, but not recovery. So we want them to have functional recovery. That's the words, okay? The keyword is to make them be able to function. That means they'll be able to go back to work, like Dr. Betty Tay, able to go back to be a cardiologist. If she's having a depression, she can go back to be a cardiologist. Okay.
Always functional.
Okay, that's very good. Okay, so, and also we want to prevent recurrence, all right? So we don't want them to have another relapse because as you know, when they have more relapse, it's more difficult to treat. So prevent recurrence. So these are the treatment phase, all right? Good. So the APA is the American Psychiatry Association. I mentioned that the mild to moderate, even severe MDD can be treated with antidepressant. All right. So any class of antidepressant, anything that you have in your clinic, let's say you have sertraline or you have fluvoxamine or you have fluoxetine, anything, waterstatin or aglomelatin, anything you have, you can use it. So they say all are effective. So the trial they have done, the trial they say the effectiveness is between 50% to 75% when you use antidepressant. That is APA recommendation. And of course, APA also make a statement on selection of antidepressant. So we have to be careful of their side effects, the safety profile, the tolerability. Of course, you have to know whether it can be tolerated or not. So it's very important as we learn about all, because every antidepressant has different aspect on this area, right? So we must be a bit careful which one to choose for our patient. And the factor to consider the selection of antidepressant therapy, I always, nowadays we talk about in psychiatry world, like which I just came back from the meeting, we talk about share decision making, like we share the decision on which antidepressant to choose. I would like to discuss with my patient, okay, we have this antidepressant for you. So like, which one would you like to use? And of course, I tell them about the side effects. I tell them about their the cost of the medication, the response of the medication, the effectiveness of the medication. I'm sure all are effective, but then because some of the medication are sedative, some are non-sedative, some can cause weight gain. I'm sure Betty doesn't want anything.
Oh, definitely not. The
So,
last on the
a
list.
lot of ladies tell me, please don't give me something that you can put on weight. Okay, so we have to discuss all this with my client. So I always discuss with my clients. Now my clients are very happy. So because when you discuss all this and you don't force them to take, okay, you just don't tell them, just go home and take this antidepressant. No, I don't do this. I will discuss with them properly, then they choose. They want A or they B. If they want A, fine. I just tell them, okay, take A. because I believe that when the patient choose the right antidepressant, the one that they want, they will adhere to it. They will take the antidepressant, because I've seen patients who don't take it. They don't understand about the medication, and then they go back and they only take for 1-2 weeks, 1 week, and then they stop. So that is not what I want. I want them to be able to continue on the antidepressant. That's why we have this shared decision making. We make the decision together. Then patient will take it. So that is very important. So try to use this method when we discuss with patient. And also try to keep few antidepressant in the clinic, not only one, so that the patient has some selection of it. All right. So you just don't offer the patient with those all putting on weight because the lady doesn't like it. So
David,
maybe,
sorry, can I stop you here? So when you ask the GPs, or let's say any of the private family physicians
yeah,
to a few selection, do
yes.
you keep the same kind of medication like SSRI and then another group of drug, or is just the same group of drug but different brand is also okay?
Yeah, it's a very good question, Betty. Basically, I would suggest to keep different classes, because we, as you know, we have SSRI, we have SNRI, we have other new group. So try to keep a different group, so it's easier to manage. So if this group doesn't work, we can use the other group. So I think it's good that we have few groups in our clinic rather than just one group of medication. All right. So I think I answered the question for Betty. Fine, so let's move on. Okay, as I said again, why the patient not adhere to our medication? Because one thing is lack of efficacy. Sometimes the medication, patients stop it because it's not effective. And also because they have adverse event. Some patients come back and tell me, say, I put on weight, doctor. I don't want to eat the medication anymore. I put on so much of weight, like in 2 weeks, I put on 5 kg. I say, okay, so what are we going to do? Okay, we're going to change to a different class, of course. We can change to different class. That's why when Betty asked me the question, I'm very glad to answer that we should have other class that not really put on so much weight. So, and also another one thing very important I see in my practice is that the stigma. You know, some patient come back to me and tell me, oh, I have stopped the medication. I say, why you stop the medication? And they say, oh, because my auntie, my parents, my friends tell me, oh, you take this mental medication will make you more mentally sick. So that's not right, okay? So please don't believe them. And I always tell my patient, please don't listen to them. They are not doctors. They are not your psychiatrists. So just stick to your medication and you see the effect. There's no such thing like when you take more mental illness medication or take more antidepressant, you become more psycho. So that's they are telling me that they become more psycho. They are afraid they become more psycho. So that is the common reason why this is cited by the patient. Okay. So when I interview the patient, also they tell me something like that, like my auntie or my relative asked me to stop taking all this medication. So it's very dangerous. When you stop taking this medication, your depression may get worse and you might have suicidal tendency. So that's what I'm afraid. All right. Good. So what is the common side effect of this antidepressant? As I mentioned, of course, the weight gain. Some of them.
Which group cause the weight gain? Which group of antidepressant?
Okay. Normally we have it's not only the classes. We have a few quite common one like metrazapine, because it affect the appetite. And of course, some of the SSRI also may cause weight gain, because most of them weight gain is because they increase the appetite of the patient, because they act on certain receptors which cause weight increase of appetite. So patients tend to eat more. When they tend to eat more, they have the weight gain. So we have to be careful. Like I think the most common one will be metrazapine, is under the as the SARI class, another class. So, and I also see most of them on sometimes they're on escitalopram, they may get a bit of weight gain also. So it's very how do I say, it's not like, it's very subjective. Not everyone will have weight gain, even though this medication can cause weight gain, but so to certain patients, it does not cause the weight gain. So it's quite subjective. So
Is the weight gain, can I ask you, is the weight gain because of an increase or better mood? For example, you are no longer depressed, you feel like everything is honky-dory, so you eat more.
How you wish.
You know.
Okay, anyway, actually you are right. So first is because I think it's the medication increase the appetite. I think the first thing is the medication increase the appetite. Second, of course, when the mood get better, they tend to enjoy more, they tend to eat more. I think that's probably the second reason. But the first main reason is the medication itself. All right, because they add on the satiety center and it can cause increase of appetite. So that's what my patient telling me. And also they make them hungry. Some of the medication can make them hungry. So they went hungry in the middle of the night. So they wake up and cook Maggi mee. So like tonight, maybe after this talk, it's like quite late. Maybe I'll cook my Maggi mee and eat. So I will put on it. All right. Okay. So besides weight gain, they have sexual dysfunction. They have nausea. Sometimes they can come to you with some sedation. Of course, sedation, antidepressant is good for those who can't sleep. And of course, constipation is quite common on certain medication of antidepressant. Dry mouth, headache, insomnia. These are the common side effects with antidepressant. All right, so let's see. So we move on. So the guidelines, okay, there are a lot of guidelines, right? I think some of you are following the guidelines. We have the Malaysian psychiatry guidelines. We have the CATMAT, the Canadian guidelines, we have the American guideline, we have the British guideline, but I don't think all these are necessary. For me, doesn't matter. Either you want to use a first line or second line. For me, it's basically, as I mentioned before, choose the most suitable antidepressant for your client and discuss with your clients so that we can ensure a good compliance. That's what we need. We need the patient to get well. It doesn't matter whether it's first line or second line. It's not like antibiotic. The first line doesn't work. Okay, you go for second line. It doesn't work like way. For me, it's which is the most effective one to make you well, because we don't want them to suffer. We want to make them well faster. So that's why I think it doesn't matter. You either go for first line or second line. For me, I go for the most suitable one for the patient. All right, good. Okay, let's move on to schizophrenia, because I mentioned about schizophrenia before. Sometimes a schizophrenic patient can present with depressive symptoms. As I say, there are studies done by Mulholland and Cooper. They also found that depressive symptom is quite common in schizophrenic patients. So when schizophrenic patients come to you, they may tell you that, doctor, I'm feeling depressed. Recently I'm feeling down. I'm like no mood. I'm sad and tearful. Then are you going to straight away diagnose them as MDD? No, right? I'm sure you're smart enough. You will be able to ask further question like, do you have previous consultation with your psychiatrist? What was your diagnosis at that time? Were you on any other medication? But for me, we can see that the schizophrenic, we have some schizophrenic phase, like the images that we can see that, oh, this is not really a depressed case. It's like a schizophrenic case. It's not like superpower that I have. It's just that after a long practice, after 20 years of practice, you'll be able to tell that this is some form of, like schizophrenic patient like that. So, yeah, so it's not a superpower. It's like there are some features.
Observation is observation skill.
Yes. So yeah, maybe it's a superpower. I still don't know. Anyway, so we can see that they might have, they might be schizophrenic patients. So we have to be careful. So in this case, yes, we have to treat the depressive symptom, right? So but our diagnosis is not MDD. This time is schizophrenia with depressed mood, right? So it's not MDD. So that's what I want everyone to know. I want the GP to know, the physician to know, the gastro to know that, okay, this is a case of schizophrenia, but presented with depressed mood. So we can either add on an antidepressant, or we can increase the dose of antipsychotic. Sometimes when you increase the dose of antipsychotic or you switch to other type of antipsychotic, it works. It will get rid of the depression. All right. So this is a thing that we do. All right. It's not that we straight away diagnose that, okay, you are schizophrenia and you also have major depressive disorder. It's not like that, because as I say, schizophrenia can present with depressive mood. Next, bipolar disorder. This is very complicated. This is quite difficult. I think a lot of people will miss it. Even I myself, sometimes I miss it. Of course, rarely I miss it. When I miss it, I don't have to be a psychiatrist, I think. I had to quit my job. I had to work with Betty as a secretary, I think. All right. So, okay, bipolar disorder. Why is it that we miss it? Because the presentation is they come at you with pure symptoms of depression. They come like they are very depressed, they are very down. They say they can't go to work. They are so sad. They are like no energy. They cannot focus. So it's definitely for you. It's definitely this is a depressive case. Yes, it is a depression case, but it could be a bipolar 1 depressive episode. That means this time is having a depressive phase. That means depression phase. So because we have the manic phase and we have the depressed phase, bipolar, it has 2 phases. They are depressive phase and the manic phase. So this time they present to you as a depressive phase. So you have to ask about whether they have any manic phase before. Try to ask. For every patient who come to you with depressive symptoms, try to ask whether they have previous episode of manic phase. Manic phase means they are very high mood. They are like, like they are very talkative. They don't have to sleep. They can stay throughout the night and be very energetic the next day. And then they'll be like singing happily. They will be like making friends with everyone, or some of them even donate you some money, So it's like a very high, like on drugs, like very high like that. So if you all have seen many patients, you can find that they are very interesting, very how you say, it's like they are like on drugs.
Very articulate, right?
Yes. So it's very interesting. But I'm just worried that we miss it because they just present to you with depressive symptoms. So we have to be aware, ask the story, ask them whether they have this, or ask the family members whether they had this manic phase before. Right? It's very important because I have you miss that. We'll give them antidepressant, and then we'll treat the depression, but then they will shift to manic. So that's what we worry. So we have to be careful on this. So because sometimes a lot of doctors miss that. Yeah, because they never ask about previous history or manic or hypomanic. So very important. So these are the this slide basically show you there are so many diagnoses. You see, the one that I'm trying to say is like bipolar 1 most recent episode is depressed. They may present with this very commonly, or they can be bipolar 2 most recent episode is depressed. So they can present to you with this. So we have to ask the previous episode, they had any previous episode on manic, important, right? So we will make a wrong diagnosis and wrong treatment. All right, so the characteristic of this is quite important slide. I think it's a good slide. You can differentiate between bipolar depression and unipolar depression. Unipolar depression means a pure depression, that's MDD. Bipolar depression means those who have manic episode and those who have manic depressive episode. Okay, so in bipolar depression, you can see I have highlight they have an early age of onset. They start early in 20s. When we say people with depression normally is lady above 40s, right? This is our common demographic. It's like ladies above 40, they are easily get depressed. But for bipolar depression cases, they start early. They might be in their 20s, early 20s, and then they have many episodes before. You ask them, they say, oh, last year I had one, and last few months I had one also. So, but the episode is very short duration, doesn't last like for months. It only lasts for a few weeks and then they get better. So this is bipolar depression. And also their mood is very unstable. They have always a very labile mood, and they sleep a lot, and they frequently have they have not much of appetite loss, and they have more of a psychomotor retardation. That means they feel very weak, just want to rest. And as I said, if you give them antidepressant, they may shift to manic phase. So that's very dangerous. So have to be careful. So we know that, okay, we have to take note. It could be a bipolar depression, right? It's not a pure unipolar depression, right? This is important. Because I think a lot of cases came like that. When you see a young man who came in, who are 18, 19 years old, feeling depressed, you have to be careful to rule out bipolar disorder, right? Anxiety disorder. Everyone know anxiety. Everyone feel anxious, right? When I talk to you, since I don't see your face, I cannot see who is anxious out there. But anyway, I didn't see Betty is anxious. Betty is happy. Anyway, so depressive symptom. Sometimes, as I say, it's always come with comorbid. I always tell my client, when you have anxiety, you have some depressive symptom, right? They always tell me, yeah, there is some depressive symptoms. So it's not a pure anxiety disorder. Normally, anxiety and depression are comorbid. So these comorbid things are very common. As I say, they are like sibling. And of course, we want to diagnose because sometimes they have more of the anxiety symptom and depressive symptom is not so much. So we don't really diagnose them as anxiety disorder. The treatment is the same. We're using the antidepressant and also anxiolytic. All right. So another thing that we have to be careful, as I said, our diagnosis is different. Is anxiety comorbid depression. It's not a pure MDD, right? Okay, another one, very simple one. This one I like to diagnose because I think a lot of people outside, they are diagnosing straight away MDD. It could be just an adjustment disorder, like when you have a fight with your partners or with your girlfriend, your wife, you feel sad, or maybe your parent just passed away, you're feeling sad. So are we going to diagnose that as an MDD? It's not. So it could be an adjustment disorder with depressed mood, right? So what is the criteria for adjustment disorder with depressed mood? So it's not the same as MDDs, as I said, it has to be, there is a stressor within the 3 months period. That means it happened within this 3 months. Let's say I have a car accident, suddenly I feel depressed. So let's say last month I had a car accident and I feel depressed. So the diagnosis is adjustment disorder with depressed mood because my car was being damaged and I don't have a car to drive to work. So I'm sad. So I'm not having depression. I maybe just adjustment disorder. So we have to dig into the history and get the right history. So it does not meet the criteria for depression for MDD. So this is what I want to highlight here. So it could be just an adjustment disorder with depressed mood. And normally once the stress is gone, the symptom does not persist for more than another 6 months. That means once the stress is gone, slowly the symptom disappear, right? So it's not like depression. It can go on for a year or two if you're not being treated. All right, so what are the symptoms for anxiety for adjustment disorder? Same like present things like depression. They have low mood, cheerfulness, feeling hopelessness. But then we manage the case by addressing the problem. We talk to the patient. What is your problem? How do you solve the problem? We tell them about problem solving skill. We do about a supportive therapy, and of course a little bit of medication can help. Because sometimes they say they can't sleep because they are quite worried about their condition, they can't sleep. So maybe we use a bit of anxiolytic can help. Or some of the doctors or some of the psychiatrists also use a bit of antidepressant may help. So either you use a little bit of antidepressant or anxiolytic, it may help. All right, good. So next we move on to OCD. I'm sure you have seen a lot of TVs, a lot of cinema from the cinema, a lot of show on OCD. Yeah, OCD people will present to you with depressive symptom because of the stress of doing the same thing again and again. They are repeatedly doing the same thing. Like they have to wash your hand, keep washing your hand. They always feel that they are contaminated, or they have these thoughts that intrusive thoughts, the recurrent and persistent intrusive thought that they keep thinking about. Okay, this person is bad, this person is bad, this person is bad, this person is bad. So these are very distressing. So they can present to you with depression. But our diagnosis is not MDD. Our diagnosis is OCD with depression. See, so that is different. So we should address their depression, anxiety condition if they presented to you, right? So proper medication, of course, to treat the OCD, it also can treat the depression itself. Eating disorder, as I said, all those models or the ballet dancer, they are very skinny because they have to be skinny. So when they are too skinny, they want to be skinny. Some of them gone to a inappropriate diet and they end up having anorexia nervosa. And normally anorexia nervosa, eating disorder associated with depressive symptoms. They come to you with feeling depressed, and when you see them, they are very thin, and then when you ask them about their diet and all these things, then you can know, maybe they are actually anorexic patient with depressed mood. So we also have to be careful. Of course, the main thing, we have to treat their anorexia nervosa, and of course, when their anorexia is better, their depression is better, right? Okay, other than that, I guess other than what I mentioned just now, the other thing would be Parkinson disease. As you know, Parkinson disease, 40% of the patient with Parkinson patient has depression. Alzheimer's disease also, people with Alzheimer's are very common. They can present to you with depressed mood. Cancer patient, definitely, diabetes patient. And I mentioned mental retardation, intellectual disability, and of course, substance related, those using drugs, using ketamine, using cannabis, all these people can present to you with depression. So we have to also ask about all this substance abuse. We also ask about they have any other medical condition, or they have any other post-traumatic. So it's not all the case. That's why I'm saying it's not all the case. It's definitely MDD. Yes, I think I'm going to finish. It's about 40 minutes. So I think, okay, my conclusion for today is what I mentioned just now. Depressed mood is not equal to major depressive disorder. We have to remember this. What I said today is that not all patients come to you when they're depressed. They are definitely a depression case, all right? Because there are other medical illnesses I mentioned just now, and also medical condition can present with low mood or depressed mood. And of course, you need a proper history taking, spend some time with your patient, talk a little bit more with your patient, do some investigation to rule out any other symptoms or other sign, so we can come to a right diagnosis, and therefore right treatment can be given. All right, good. So finally, thank you for your attention. Of course, if you need any more information, these are all my contacts. My Facebook, your psychiatric clinic, of course, my phone number, all are there. You can take a snapshot, and if you have any question, you can ask me. All right, I think back to you, Betty.
Hi, okay, very interesting. But I want to ask you, is some of the disorders, for example, anxiety disorder and panic attacks and OCD, something new in the society? Is it, I don't see when I was a kid that we had all these issues.
Okay, the voice is breaking.
Okay, can you hear me? Can you hear me? Okay, I think the Wi-Fi is.
No, okay.
Okay, can
Okay,
you?
now it's better.
Okay, so
Now it's better,
basically,
yeah.
I want to ask you, it is not related to diagnosis or differential diagnosis, but is anxiety, panic attack, and OCD a new disease or something that is new in this society? Because I don't see it when I was maybe starting off my career, or when I was a child, or in my, teenage years. But I see a lot among the kids these days.
Yeah, it's not something new. I think last time, I think it has been there. It always has been there, because this illness has been exist for a long time. It's just that I think the reason is because last time the lack of psychiatrists. Last time when I was younger, there are only like maybe in Malaysia only less than 100 psychiatrists. That's why I think a lot of cases are not being diagnosed, are not being treated. So it's not something new. It has been there. It's always been there. And recently, because a lot of people are more aware of this illness, they are more aware. They have seen, they have seen from the TV, or they have seen from the articles from the newspaper. They come forward to look for help. That's why now we see more cases. And also because of the pandemic thing, a lot of people are suffering anxiety, and they know about these are all anxiety, these are all depression. So it's not something new. It has been there, but these days people are more knowledgeable. They are more aware. That's why they came forward, and that's why you see a lot of cases these days. Even I have students who actually ask their parents to bring them to see me. So I think it's good. They are very aware.
Yes, they're very aware. Even my children.
I hope I answered your question.
Yes. But I still think, okay, I need to see the chat now, because I shared this thing here. I can't see the chat. So let me just just let me share the questions in Facebook first. No Fadila asked, okay, what can we
Okay.
do to help these depressed patients? Because and I think that she's talking about maybe as family members or as friends, because sometimes these people tend to be very quiet.
Okay, of course, you asked, the question is quite general. So
Yes.
if you're talking about helping, of course, I think a simple thing. If they are your friends, of course, we can help them to, because some of your friends are probably they are depressed, but they are still have to take care of their children, they have to do housework. So maybe offer some help, simple thing. Maybe offer to drive the kids to school, maybe help them to cook something, or help them to basically to release their burden. I think this is something you can help. And of course, spend time to talk to them. It's very good if you can spend time talk to them. As a friend, if your friends are depressed, it's good that you can talk to them, spend some time. And also, just now I mentioned, help with their housework. Also, it can be helpful, like bring their children to school, bring their children to tuition, things like that. Simple thing. You don't have to do big things. You are not like, you don't have to like bring medication to them. What I mean, you also can bring them to see a doctor if you want, but just small thing helps. Yeah, I think spending time also it helps, right?
Okay. Let's take some questions from Dokwiti. Dr. Manjit asked, can Parkinson's disease lead to depression? If yes, do you treat the primary disease only, or depression needs to be treated as a separate entity?
Yeah, Parkinson's disease I'm shown just now I mentioned. Parkinson's disease actually is actually can lead to depression. They have study have shown that 40% of the Parkinson patient have depression. So normally you add on antidepressant for Parkinson's disease. Like when my neurologist referred to me, patient with Parkinson's disease, I will add an antidepressant for it if I find that they're having depressed. So I think it's quite common. Try to look for depression in Parkinson's disease, which is quite common because, as I said, the study has shown 40% of them actually have depression. All right, so we can add any of the antidepressant with to this group of people. All right.
Okay. Yip Mei Ching asked, why from Facebook, why mostly old people when they are unable to sleep and sometimes they shout at night? What kind of medication is suitable to calm them down?
Okay, all people who can't sleep and they shout at night. So we have to be, for me, we probably have to interview we have to see the patient first. Sometimes I'm afraid they might have a bit of dementia. I don't know. A lot of them come to me with this type of symptom. Normally they are suffering from some form of dementia. Could be an early dementia or moderate dementia. So we have to look out to check whether they have dementia or not, because a lot of older people with undetected dementia. So when at night, they tend to have probably some delusion, they can't sleep, that's why they are shouting, they're restless. So we have to treat the condition, of course, with some antipsychotic. So normally I'll use some antipsychotic will help in this group of people, or some antidepressant with antipsychotic will help. But of course, have to be assessed by a psychiatrist or geriatrician first to make sure are they having other things like dementia or not, or they are having depression. So we just want to rule out first so that we can give a proper treatment. So I think we need attention for this group of people, right? It's not like they simply want to shout. It's not like when I grow old, then I will like simply shout. It's not like that. Okay, I think there must be some underlying issues. Please get them to see a geriatrician or a psychiatrist to rule out any. It could be an early dementia, as I mentioned, or maybe it could be a case of depression. Right. Good.
Okay.
Good question.
There are a lot of questions.
All
Okay.
right.
In patients who are grieving at one point, do we treat them with antidepressant, depression if their grief is affecting their function?
All right, a very good question. For me, when the grief is affected your functioning, as I say, because we want to achieve functional recovery, right? So I would recommend antidepressant for grieving. Although last time in previous year, we don't use antidepressant for grieving, people who are grieving. We just use counseling and we do some therapy. But now I think if affecting their functioning, they cannot function, I think a bit of antidepressant with anxiolytic will help. So you can use antidepressant with a bit of anxiety. I think it will help a lot. You can see so much improvement in the patient. Yeah, for short term, right? All right, good. Good
Peter
question.
asked, is adjustment depression the same as reactionary depression?
Nowadays we don't use reactionary depression anymore. I think it's not the term we use. As I say, adjustment, we normally say adjustment disorder with depressed mood. All right, that is the DSM-5 diagnosis. And reactional depression, yeah, you can say it could be this. Okay, this is the old term where reactional means you are reacting to something, that's why you are depressed. I think basically it's about the same, but I think it's just the terminology that we're using now. We are using more like an adjustment disorder with depression mode, right?
Okay,
Right.
from Docwitty, doctor asked, does being a neat freak, neat, being not the knitting,
Okay, yeah,
okay,
yeah.
and a perfectionist considered as OCD, and can it cause depression as well?
Okay, you're playing neat. Okay, neat is good. I always like people who are neat.
Oh, you won't like me then.
So it doesn't mean that if you are neat,
Yourself.
maybe I would like you. You are neat person. So so it may not be a condition we call OCD. Okay, depends on how neat you are. If you are keep cleaning the place again and again, although even though it's clean and you do it again and again and again, and it become some sort like a stress to you, affect your life. Once it affect your life, then we will say is a OCD. When it affect your functioning, because like certain people, they have to shower for a few hours only they can go out from the house. So that's considered not right. That's considered already OCD, because they say they are not clean yet. They have to clean. They have shower for 2-3 hours. I have patients who shower for 6 hours before they can come out from the toilet.
Yeah.
So this is not well. This already affected her life, because half a day is gone. She has to go work in the afternoon, cannot go work in the morning, because it affected her life. So this is OCD. If you are just neat person, I love you for that. Okay, not to worry.
Okay. So somebody from Facebook, Ivan asked, Ivan Low asked, high function depression has become more common. Now, I don't know what is high function depression. How do we diagnose them and treat them?
Okay, high function depression is probably we don't use this term yet. I mean, recently probably you're trying to mean what you are trying to say is probably a mild depression. We call it a mild depression. That means or either we call it dysthymia. Is more of a milder form of depression. So yes, we can, they have some depressive symptom, but they can function, they can hide their depression. But when you really go deep inside and they do therapy, you find that a lot of issues inside them, but they still can function. Like me, maybe you think I'm having a depression, but then I still can function. Maybe I'm depressed down inside. Nobody knows, right? So this group of people, of course, we need some, probably I would suggest a psychological assessment by a clinical psychologist to help them to discuss about what is bothering them, because they are considered mild depression or dysthymia. So maybe they don't have to need, they don't need antidepressant. They may need some therapy will help. So I think probably a clinical psychologist can help in this case. All right, Ivan, thank you for a good question.
Okay, so now we go back to Docwitty question. Dr. Shivaji asked, normally GP refers antidepressant cases to psychiatrists. Can GP treat with psychiatric treatment?
Yeah, I think very good question. Yeah, GP, if you are well versed with antidepressant or antipsychotic, yeah, you by all means you can treat, because I think a lot of I've seen a lot of GP are treating depression case, mild to moderate depression case. Of course, they send me all the severe case, difficult case they send to me, of course, right? So they don't want to take the burden of like suicidal case or anything, they send to me. But normally they treat the mild depression case and moderate depression case. You all can order antidepressant as usual, and of course you all can treat depression, because in Australia or other places, the GP are very good in treating depression case. Right. So
the cardiologist is also very good at treating depression.
Yeah, I believe so. I believe so.
Because so difficult to convince patient to go to see a psychiatrist sometimes, and they with palpitation and psychosomatic
yeah,
symptoms.
I think cardiologists and gastroenterologists see a lot of depression cases. Yeah, just that either you want to treat or you don't want to treat. So I'm sure GP also can treat. You also see some depression case, anxiety case, and I'm sure if you are familiar with your drug, yeah, by all means you all can treat.
And sometimes it can be quite satisfying, patients with panic attack, gone to
Uh-huh.
ER so many times.
Yeah.
And then, so the patient themselves also. So I want to come to this question by me. How do you tail down when you say recovery phase? How do you tail off the antidepressant? And what is the chances of them coming back again?
Okay, very good question, but I'm not telling you the answer. So
How
I can have some business, or else you're taking all my business.
okay.
I can't do this deep question. Okay, I have to answer to the question. Okay, it's a very simple question. Okay, normally when we are talking about well means they have recovered. That means they have no more symptoms for at least 6 months. For if you are the first episode, you must be well for at least 6 months. I want you to be well for at least 6 months. I mean, no symptom, no depressed symptom for 6 months, and you're functioning for at least 6 months, and then we can gradually tail off your medication. It means go half and then quarter, then we stop the medication. All right. So, but if you are having this depression for 1 and 2, this is your second episode. Normally we go for 1 to 2 years. You have to be well for 1 and 2 years. At least 1 to 2 years, you must be well. Then only we are willing to stop the medication. If you are having more than 2 episodes, let's say you have 3 episodes, 4 episodes already, we will advise antidepressant for a long time. That means like for a long time. Okay.
Yeah.
So because we believe that studies show that those who have 3 episodes of depression before, or 4 episodes of depression before, they will have another episode. So we want to prevent them from having episode. We will encourage them to take continuation of this antidepressant. Right. So this is my takeaway tips.
Okay. Does bereavement is same as adjustment depression? I think so, right?
Yeah, at this moment, we have take out bereavement in our DSM-5, so we put it together adjustment
Okay.
depression thing. Yeah.
Okay. Cynthia asked 2 questions from Facebook. If a patient is still depressed from an event 4 years ago, is it adjustment disorder?
Oh, it's already 4 years. So because like just now, I think you didn't see my slide properly.
Yes,
I need to punish you just now. So because I said it happened, it has to be within 3 months. Anything stressor within 3 months, we can say adjustment. If it's over 3 months, if the incident already happened after 3 months, I don't call it adjustment anymore.
Okay.
It could be depression. All right. So naughty girl just now. All right.
And the other thing she asked is there any blood investigations that you would suggest to actually do as a part of an MDD workup?
Okay, MDD, normally we are afraid is because, as I said, they could have some thyroid problem. So normally I will do a thyroid function test. I think usually I'll do a thyroid function test to just rule out thyroid issue. But of course not frequently unless they come with palpitation, because I think all these hormone thing can affect depression. So for me, usually if they are very clear cut of the depression, classic case of depression with all the symptoms, I don't do much of the blood test unless they have some palpitation, they have some symptom look like maybe hyperthyroid toxicosis or things like that. Then I'll do a thyroid function test. Normally, I think, or they can be some other, they have some fever or this, then you have to be careful. Maybe a MRI, be afraid it could be brain infection coming in, presented with you with depressive symptom. It could be bring some meningitis, things like that, if you have some fever, things like that. So we have to be careful, because I have a patient before who actually come in looking very depressed, but she still can talk to you, but no fever. But then later on we found that the fever came in. Then we do a scan. She has a meningitis, so it can present with a depressive symptom.
Oh
So
my God.
so you have to be careful on this. So so if the patient look very sick, but then they say they are depressed, but they look very sick, you can see that they are medically very sick. So so just be careful. Maybe we need to do MRI in that case, right? But for blood test, I usually only do the most, I think, thyroid function test. Of course, for baseline, you can do liver function, kidney function test, and of course the full blood counts, right?
Okay,
Okay,
Dr.
I will
Nabila
answer
from
that.
Dr. T asked, in
Yeah.
major
Any
depressive,
more questions?
a lot lah, still a few. Okay, we take a few more lah, huh? Dr.
Okay.
Nabila from Dr. T asked,
Okay.
in major depressive disorder, do we start antidepressant immediately during the patient's first visit, or do we refer them for counseling before we start medication?
Okay, thank you very much, Dr. Nabila, for your good question. Of course, if you diagnose them already major depressive disorder, you may start antidepressant straight. To me, I will start straight. That means from that day, if you already confirm this patient is suffering from depression, why not you start antidepressant so the patient don't have to suffer so long, right? If you don't start, the patient is feeling depressed, and when they use time for counseling only can help in a long, I mean, it take a long time for the counseling to work. It doesn't mean you go counseling today and tomorrow I'm fine. So but antidepressant work faster than counseling. Of course, you can, for me, I would suggest you do both together. You start antidepressant at the same time, send them for counseling. So at least that's why I say we do biopsycho treatment, biopsychosocial treatment. So bio is we starting antidepressant, psycho means you refer them for counseling, or your psychologist can help to talk about their issues. Right. So I think two together is the best. All right, I answered the question.
I think the message here that you actually said, it is very important to realize this depression, there is a lot of suffering.
Yes.
A lot of suffering. And then just like anxiety, a lot of fear. One patient told me, doctor, you don't understand. I have been fearful all my life over the silliest thing. Like if I see a crack over the cup, it just gives me panic attack. And I don't want to live like that. But again, he has seen so many people, and because he's been shopping and he didn't believe in taking medication on a regular basis.
Yeah.
Dr. Kamala asked, in a GP setting, what drug can we give in case they have depressed mood with Prestig work?
Okay, Prestig is one of the SNRI, is venlafaxine. Of course, it works. You
Oh,
can,
well,
if you are familiar with Prestig, you can try Prestig, of course, 50 milligram, or antidepressant work, as my slide was saying. And the American Psychiatry Association also agree with that. All antidepressant work. So, but depend on which one you want to choose for your patient. You tailor custom made or customize for your patient. Which one is the best for your patient? Which one you would like to use for your patient? So Prestig is venlafaxine SNRI, it works. So you can try on your patient. If he has no sensitivity to give Prestig, you may try Dr. Kamala. You can try on your patient. It's not a problem. Of course, just watch out for any of the side effects. Sometimes they get a bit of nausea or headache like that, but I think it's quite rare. You may start Prestig. If you have Prestig in your clinic, you may do so. It's not a big issue, right? So to me, any antidepressant work, but then of course you must choose the most suitable one. As I said, certain antidepressant may cause weight gain. Certain antidepressant is very sedative. Your patient may not like it, so they choose the right one for them. All right.
Okay, we got two more questions. I think we will answer them. And would you diagnose a patient with depressive symptoms but not affecting work or life with MDD and perhaps adjustment disorder first? Okay, I think that's very vague. I think it should be a very good history first. Okay,
never mind.
yeah.
So okay, so the question is very basically, is this adjustment disorder or is this MDD? Because as I said, there is criteria to follow, right? So if you want to diagnose them as adjustment, then it has to be the person is experiencing something that is so stressful within 3 months. So then they feel a bit fear, feeling down, tearful, no mood. So that is still under adjustment. That is over 3 months and then affecting their life. Then it could be a MDD. So MDD is more like the criteria that I mentioned just now in my slide. I talk about loss of interest and depressed mood that must be there, right? Either loss of interest or depressed mood must be there. Either one of these, and of course other symptoms like loss of focus, cannot function. So that case could be a mild depression, because we always categorize them mild, moderate, or severe depression. So that could be a mild depression, or it could be an adjustment disorder, depend on the timing, right? So if I just had an accident, like the son I said, if I just knocked down my car last week, then today I'm feeling depressed, could be just an adjustment, right? This is just an example. But if I had my car 1 year ago, now I'm depressed, then it could not be an adjustment disorder. It could be a major depressive disorder. All right, good.
Okay, so to all the nurses, the eCert link is on Facebook. Go to the eCert link on Facebook, yeah. So go to Facebook, Beating Heart's Facebook page, and the eCert link is there, and it will be there for another half an hour. So AJ asked whether patients with schizophrenia, is it necessary to get IM haloperidol monthly? Is it?
No. Okay. We only give depot. This is called a depot injection now, because haloperidol is a very old antipsychotic, and it's only given in I think only given in a government setting. I don't use haloperidol anymore in my practice. Because a lot of side effects. So haloperidol, we don't use haloperidol as a depot. So, but it's just to for the restless patient. I think cardiologists or whoever physician use it like something to give you to make you not restless, just a temporary effect. Like let's say your patient is shouting in the ward, getting restless after post operation or post surgery or anything, then we give haloperidol just to sedate them. So it's not monthly thing. Monthly we have some other depot. Like I mentioned, we have Cropixol, we have Fransol. These are the older type. Of course, we have a newer type like paliperidone, we have Maintainer, a lot of new depot we can use for monthly injection. Now even we have 3 monthly. That means you need to take every 3 months. One jet lasts you for 3 months. So we won't have that now. So it is easier for the patient with schizophrenia. All right, I think it's good. I think everyone have
I think we have we have answered all questions. Okay, if you are looking to renew your indemnity insurance, do consider Dr. Shield, and you can use the promo code HEARTS 2021 for a discount. And this QR code is for doctors. You use the MMA app to scan, and you will get 1 CPD point. Okay, and for the nurses, go to Beating Heart's Facebook page, like the page, and then you can get the eCert from there. It was a very interesting talk. Okay, I will stop recording right now.